था ना।
हर बात की कहानी आज बरसे का पानी। ओ पिंकी के पापा प्लीज प्लीज टेक द छाता।
प्लीज टेक द छाता भाई साहब, प्लीज टेक द छाता।
मैंने बोला था ना।
लाल पीला हरा नीला साथ में धुलाएगी, व्हाइट कपड़ों पे क्या रेनबो बनाएगी।
मैंने बोला था ना।
पिंकी बेटा लेसेस, डोंट मेक दोस फेसेस। याद आएगी माँ जब गिरोगी।
मैंने बोला था ना।
बिजली की है तार, भैया बनो नहीं स्टार। हाँ यस नो नहीं।
मैंने बोला था ना।
सबको दिया ज्ञान पर खुद का नो ध्यान। हुआ फीवर थकान, अरे अब तो जाओ मान।
मम्मा एनर्जाल।
पी लो। वेक्टरबॉर्न डिजीजेस जैसे डेंगू, मलेरिया, चिकनगुनिया और टाइफाइड से हाई फीवर होता है। इस दौरान कम फ्लूइड कंजम्पशन और इलेक्ट्रोलाइट लॉस की वजह से पेशेंट की बॉडी डिहाइड्रेटेड रहती है। अगर इस दौरान पेशेंट अच्छे से हाइड्रेटेड रहे तो वो जल्दी रिकवर हो सकता है।
मम्मा मैंने बोला था ना।
हाँ जी मिसेस शर्मा, शुरू करें।
हेलो हाय, हेलो हेलो हाय। सारा दिन फोन पे रहती है ये कमला। गिरा 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 मेरा गमला।
मैंने बोला था ना।
हर बात की कहानी आज बरसे का पानी। ओ पिंकी के पापा प्लीज प्लीज टेक द छाता।
प्लीज टेक द छाता भाई साहब, प्लीज टेक द छाता।
मैंने बोला था ना।
लाल पीला हरा नीला साथ में धुलाएगी, व्हाइट कपड़ों पे क्या रेनबो बनाएगी।
मैंने बोला था ना।
पिंकी बेटा लेसेस, डोंट मेक दोस फेसेस। याद आएगी माँ जब गिरोगी।
मैंने बोला था ना।
बिजली की है तार, भैया बनो नहीं स्टार। हाँ यस नो नहीं।
मैंने बोला था ना।
सबको दिया ज्ञान पर खुद का नो ध्यान। हुआ फीवर थकान, अरे अब तो जाओ मान।
मम्मा एनर्जाल।
पी लो। वेक्टरबॉर्न डिजीजेस जैसे डेंगू, मलेरिया, चिकनगुनिया और टाइफाइड से हाई फीवर होता है। इस दौरान कम फ्लूइड कंजम्पशन और इलेक्ट्रोलाइट लॉस की वजह से पेशेंट की बॉडी डिहाइड्रेटेड रहती है। अगर इस दौरान पेशेंट अच्छे से हाइड्रेटेड रहे तो वो जल्दी रिकवर हो सकता है।
मम्मा मैंने बोला था ना।
हाँ जी मिसेस शर्मा, शुरू करें।
हेलो हाय, हेलो हेलो हाय। सारा दिन फोन पे रहती है ये कमला। गिरा 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 मेरा गमला।
मैंने बोला था ना।
हर बात की कहानी आज बरसे का पानी। ओ पिंकी के पापा प्लीज प्लीज टेक द छाता।
प्लीज टेक द छाता भाई साहब, प्लीज टेक द छाता।
मैंने बोला था ना।
लाल पीला हरा नीला साथ में धुलाएगी, व्हाइट कपड़ों पे क्या रेनबो बनाएगी।
मैंने बोला था ना।
पिंकी बेटा लेसेस, डोंट मेक दोस फेसेस। याद आएगी माँ जब गिरोगी।
मैंने बोला था ना।
बिजली की है तार, भैया बनो नहीं स्टार। हाँ यस नो नहीं।
मैंने बोला था ना।
सबको दिया ज्ञान पर खुद का नो ध्यान। हुआ फीवर थकान, अरे अब तो जाओ मान।
मम्मा एनर्जाल।
पी लो। वेक्टरबॉर्न डिजीजेस जैसे डेंगू, मलेरिया, चिकनगुनिया और टाइफाइड से हाई फीवर होता है। इस दौरान कम फ्लूइड कंजम्पशन और इलेक्ट्रोलाइट लॉस की वजह से पेशेंट की बॉडी डिहाइड्रेटेड रहती है। अगर इस दौरान पेशेंट अच्छे से हाइड्रेटेड रहे तो वो जल्दी रिकवर हो सकता है।
मम्मा मैंने बोला था ना।
हाँ जी मिसेस शर्मा, शुरू करें।
हेलो हाय हेलो हेलो हाय सारा दिन फोन पे रहती है ये कमला गिरा 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 मेरा गमला
मैंने बोला था ना
की कहानी आज बरसेगा पानी ओ पिंकी के पापा प्लीज प्लीज टेक द छाता
प्लीज टेक द छाता भाई साहब प्लीज टेक द छाता
मैंने बोला था ना
लाल पीला हरा नीला साथ में धुलाएगी व्हाइट कपड़ों पे क्या रेनबो बनाएगी
मैंने बोला था ना
पिंकी बेटा लेसेस डोंट मेक दोस फेसेस याद आएगी माँ जब गिरोगी
मैंने बोला था ना
बिजली की है तार भैया बनो नहीं स्टार हाँ यस नो नहीं
मैंने बोला था ना
सबको दिया ज्ञान पर खुद का नो ध्यान हुआ फीवर थकान अरे अब तो जाओ मान
मम्मा एनर्जाल
पी लो। वेक्टरबॉर्न डिजीजेस जैसे डेंगू, मलेरिया, चिकनगुनिया और टाइफाइड से हाई फीवर होता है। इस दौरान कम फ्लूइड कंजम्पशन और इलेक्ट्रोलाइट लॉस की वजह से पेशेंट की बॉडी डिहाइड्रेटेड रहती है। अगर इस दौरान पेशेंट अच्छे से हाइड्रेटेड रहे तो वो जल्दी रिकवर हो सकता है।
मम्मा मैंने बोला था ना
Good morning. Today I'm going to show you 4 patients. The first patient is a case of atrial fibrillation. Atrial fibrillation is a very, very common, even the laymen now know what is atrial fibrillation because it can present at any age, and there are dozens of causes which can cause atrial fibrillation. Really speaking, atrial fibrillation is difficult to treat and drugs don't work, especially after initial 2-3 months. Then you must do some electrical conversion therapy. I'm sure all of you must be having at least one patient of atrial fibrillation, maybe more because they last lifetime. So let us start with the first patient. Maruti was treated for atrial fibrillation. He was given amiodarone and he responded. Atrial fibrillation disappeared. That every doctor must know atrial fibrillation. It is the commonest heart disease in private practice, where the atria, this means the atrium instead of ventricles, instead of contracting like this, they are like this. They are not contracting. They are only trembling. Now, when this thing happens, the blood will not be pumped out properly and it remains there, and you will get blood clot formation. Exactly like in a prostate patient. A prostate patient, for most important, you must tell him pass urine twice. Because if he doesn't pass urine twice, something remains after the first urine in the bladder, and that's which gets infected and produces more problems. Similarly, these people tell you, now if there is a clot in the left, say both atria, say left atrium, now you can see that clot can move forward and can go anywhere in the body. If it goes in the brain, you get hemiplegia. It goes in the spleen, you get splenic infarct. It goes in the limb, you get a gangrene of your. What a nuisance it is, you can't imagine, if you develop a clot. So now we have to prevent the clot. For that, anticoagulant is lifetime. This morning I was discussing antiphospholipid syndrome. You give them anticoagulant is lifetime, they can develop coagulation, clotting anytime. Now here, Because of atrial fibrillation, you can develop a clotting in an abnormal area which can spread and embolize. Horrible illness. I am not saying that you die if you get atrial fibrillation. My patients are living for 20 years with atrial fibrillation. What's the problem? But problem is drugs. If you take drugs which make the blood thin, then you do every 3 weeks you need a blood test of INR. So every 3 weeks to get poked. And if your INR blood is not in a good level, instead of between 2 and 3, 3.5, it goes to 5, 6, you die. You can have bleeding in the brain and die. It's a terrific nuisance. So if you can prevent atrial fibrillation, nothing like it. If you can prevent, I'm not saying it's preventable all the time, but one of the causes of that is hyperthyroidism. If you develop hyperthyroidism, for example, most of the patients with thyroid have got tachycardia, fast pulse, okay, but it can also produce atrial fibrillation, where the atrial pulse rate becomes very fast. This patient, he's been doing so much of nakharas with me about coming, this, that. Right? This is his file, right? Yes. We're going to give him this file. But what I told him was that this man had, when I took the history, naturally, he responded, I was interested to know why did he develop atrial fibrillation? Unless I know the cause, how can I look after him? So I found out that he had lost 10 kilo weight and diarrhea. Every 2 years I show such patients. Increased frequency of stool, which people call diarrhea. Extremely common I have seen in this hyperthyroid patient. This fellow was passing more frequent stools and he lost 6 महिन्यातून तुमच्या 10 किलो वजन कमी झाला.
हो झाले
किती?
10 किलो झाले.
10 kilo. In 6 months, the fire brigade man has to be strong, no? What fire he is going to, काम काय करणार तुम्ही? ते pipe कसा तुम्ही उचलणार? This is such a heavy pipes of water which they have to throw. And this man doesn't bother. I said, what nonsense. If you have lost 10 kilo weight, 100% you have got thyrotoxicosis. And when I got his blood test done, the only endocrine organ I teach in these 10 lectures is thyroid. Nothing else I teach. Endocrinology, according to me, endocrinology is not seen in private practice. Pituitary gland, this gland, adrenal gland, all that parathyroid gland, all that nonsense and all. Nothing. The only thing you are saying in practice is thyroid, every day. More thyroid, less thyroid. More thyroid, less thyroid. Abundant. And being missed by doctors. Why missed? They are not aware that it is so common. There is nothing to miss it. They are not aware. Now here is a blood test, which anybody he has lost weight, 10 kilo weight. He has no diabetes, his sugar is normal. Now, he has no tuberculosis, his chest is clear. There has to be thyroid. He had little tachycardia, that was enough. And you see the blood test. Now see, T3 upper limit is 200, here 349. T3 is more important in thyrotoxicosis, not T4. But T4 is also slightly high. And then what happens? If you do only TSH, and don't do this, you can diagnose hyper and hypothyroidism, both. You can save the money of these 2 tests. You do these 3 tests, it's 450 rupees. You do only 1 test, it's 100 rupees. I will do 1 test. I am just trying to work out. One test, can I diagnose everything? Now, TSH is actually not a thyroid hormone. It's a pituitary hormone. Thyrotropin stimulating hormone. Thyrotropin. Pituitary is trying to produce this hormone. How does it help? When the thyroid is less in the body, the TSH increases to more than 5. Upper limit is 5.5. It increases, but the lower limit is 0.3. If it goes to less than 0.3, then you have got more thyroid in the body. See, I don't need T3, T4 level. I don't want to see them. I'm talking about poor patients. I want to save money and make more often diagnosis. Then why should I send for T3, T4, TSH? These are only important in those pituitary hypopituitarism where there is hypothyroidism. Very rare in private practice. I don't want to diagnose that. So you can see his a thyroid has reduced to less than 0.01. 0.01 is very low, very low. If your TSH level goes low like this, then you are developing hyperthyroidism due to your tablets, which can cause atrial fibrillation, which can cause osteoporosis, which can cause myopathy. See his thyroid scan, very dark uptake, markedly increased uptake, see, markedly increased uptake, black, and this black which I am showing you, thyroid radioactive uptake, is today, here show this, now it can be described in quantitatively. Quantitatively he is writing that it is increased, thyroid uptake is 22%, normally up to 4%. His thyroid uptake is 8 times more than what it should be. So, he has got severe thyroid, this happens in Graves' disease, thyrotoxicosis. And if it is Graves, if you want to confirm the Graves' disease etiology, you must do the TSH receptor antibodies. But the fact is, TSH receptor antibodies is the test ultimately to show that this is Graves' thyroid disease. And the treatment of this particular patient is to give him radioactive iodine by mouth, which will go in the thyroid and destroy the whole thyroid. With the result, this patient now, from hyperthyroidism, he will become either normal thyroid or slightly hypothyroid. If he becomes slightly hypothyroid, lifetime I can give him thyroid tablets. If I don't ask for iodine, the next solution is to remove this gland by operation. And I am telling you, in my practice, in the last, I think how many, 20, 30 years, I don't even remember, since I was in Jaslok, yes, maybe 40 years, I have not sent a single patient for surgery. Because if you try to operate on this thyroid gland, not only the expense is too much, but the complications, you know, the parathyroid glands are removed by mistake, or they get necrosed, you develop tetany, recurrent laryngeal nerve gets damaged, hoarseness of the voice develops permanently. So it's not a good operation. Best thing is to leave the operation, give him radioactive iodine. In this case, I would like to bring out 2 points. Number one, though atrial fibrillation is a cardiac disease, atrial fibrillation means irregular rhythm, irregular rhythm. Every family physician must know that there is a cause which is a reversible cause of atrial fibrillation, which is not in the heart, the disease is outside the heart, in the thyroid gland. Atrial fibrillation is a very bad disease for a family doctor to handle. It persists lifetime. They produce clots, they develop hemiplegias, they have to be given anticoagulants and whatnot. But I was trying to impress that if you can find a reversible cause of atrial fibrillation and make the patient into sinus rhythm, lifetime, that patient is not a liability. If you noted in this patient, his atrial fibrillation was seen by some cardiologist, he was given amiodarone, which is an antiarrhythmic drug, and he became, his ECG converted to sinus rhythm, and he was left. Only when I heard the story that he had atrial fibrillation, I wanted to know, did he have a reversible cause? And one of the most important reversible causes is hyperthyroidism. And the very fact he had lost 10 kilo weight, I was sure, and he had persistent tachycardia. In my clinic, I was 100% sure, and increased bowel movements, very important. Most of these patients pass stool 2-3 times a day, so they don't even mention to the doctors, or some doctors treat it as diarrhea. So such a patient I thought he had hyperthyroidism. Mind you, his local thyroid signs were minimal. So it's a thyroid blood test which confirmed the diagnosis. And I was trying to impress on you that T3, T4, TSH alone can also diagnose thyrotoxicosis. The next thing I was trying to impress on you is that if you want to treat these patients, you have to give them radioactive iodine. Before you give radioactive iodine to any patient to kill the thyroid gland cells, make sure that you are not missing another common cause of hyperthyroidism, which is called as subacute thyroiditis. Subacute thyroiditis is unlike mentioned in the textbooks in small print. It's extremely common, and this patient can present as little fever and loss of weight. They can present as little loss of weight, not feeling well, a little tachycardia. The thyroid test shows more thyroid. Don't send them for radioactive iodine. Radioactive iodine is meant only for Graves' disease. Graves' disease is an autoimmune disease of the thyroid, a specific type of autoimmune disease, where the diagnosis is made only by blood test of so-called antibodies to TSH receptors. Mind you, this test is not being done by 99% of pathologists in India. It's only 1% who do. And once you have this report, with this report, if you can show, and suppose this report is not available, you can get a good hint from the thyroid scan, because in Graves' disease, the trapping of the isotope is so much, the whole gland is black. As I showed in this patient, he had 22% trapping. While in subacute thyroiditis, which is another cause where you can get increased thyroid hormones in the blood, the thyroid uptake is poor. It's opposite. The thyroid uptake is very minimal, which is not compatible with increased thyroid levels in the blood. So these are the 2 points I wanted to bring out in this patient.
Thyroid atrial fibrillation, as I said, is so common. In olden days, in all the young women, we used to have as many as 5 to 6 women lying in the wards with atrial fibrillation due to mitral heart disease. The commonest cause of atrial fibrillation in a young woman, even if somebody says echocardiogram is normal, repeat and write down in that echocardiography that we want to see the mitral valve specifically, because mitral valve, and even if you operate on mitral valve or do mitral valve dilatation, even then these people later on remain prone to get atrial fibrillation as they grow old. Anyhow, that is one of the common causes. Then the question is, nowadays, elderly people, after the age of 80, 10% people will have atrial fibrillation. 10%. So don't miss it. Yes, it could be slow atrial fibrillation. There is no tachycardia, so no cardiac failure. No cardiac failure. Then in the middle age, around 20, 30s, 40s, nowadays we are seeing a common cause of atrial fibrillation is called binge drinking. What is binge drinking? Today the new generation, young generation, 20, 30s, 40s, they are working very hard. They work very hard really. Monday to Friday, from morning to night, they are on the computer and really they work very hard. So much hard that Saturday, Sunday, they want to enjoy. They want to enjoy. So when they, Saturday, Sunday, when they go to enjoy, they don't drink 1 bottle of beer, 2 bottles of beer, 3, 4 bottles of beer. Now, if you drink like that, that can send you to atrial fibrillation. So when you have atrial fibrillation, you might will develop cardiac failure, temporary. But these are all temporary things to be diagnosed by the physician, by the history. So you don't frighten him. That's a lifelong disease. So this much about atrial fibrillation. There are some neurological causes of atrial fibrillation. You'll be surprised. Last time I had shown you one myasthenia gravis patient. Myasthenia gravis patients are prone to thyrotoxicosis, and thyrotoxicosis causes atrial fibrillation. Similarly, the next patient, we are showing you some of paralysis. These paralysis patients are prone to develop thyrotoxicosis. So get their TSH levels done. Let us see. Next patient.
Now I'll show you another paralysis. What paralysis? That you people in the medical colleges, and by the time you become doctors, you have only seen hemiplegia, hemiplegic, paraplegia, upper motor neuron type. In practice, you will never see those paralysis. In paralysis, what you see in private practice is this paralysis. नमस्कार शांता जी, अरे आज तो ये हीरोइन लग रही, हम पेशेंट लग रहे हैं इसके सामने। क्या इधर 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 आओ, इधर आओ, इधर आओ, इधर आओ, इधर आओ। उस दिन आपने इतना हमको तंग किया, वो नेहा के जैसे हमको इतना तंग किया। क्यों? ये क्या हो गया मेरा, ये हो जाएगा। आई टोल्ड हर आपको कुछ नहीं, इसे मामूली प्रॉब्लम which you are trying to make it a big issue and all that. God has given you so much problem and all. 52 years old, she looks hardly 35. तुम 50 की लगती नहीं, तुम 50 की. And at the age of 52, she got some problem for which she was grumbling like hell. And then what happened? That 3 times it happened that she felt weak and all the 4 limbs became paralyzed. She could not move hands and feet. What is the difference between weakness and paralysis? What is the difference? Weakness has got 100 causes, 100. I am telling you, I have seen in weakness, if I have to discuss a talk on weakness in this auditorium, I need 6 hours only to talk on weakness. I will show you patients and patients of weakness, you will be shocked, Then I'll show you weakness, how patient comes and also he walks better than you and he so hefty fellow and all. When he sits down, you ask him, क्या होता है? And he says, kamzori. What? Kamzori? I saw this fellow like a hero, he walked and what kamzori means, what the hell he is talking? But the fact is, that is a symptom of weakness. That patient has sexual weakness. Is weakness. So they think it's due to physical illness. So they are telling you weakness. That's not the point. Point is weakness can be cardiac, your heart is not good, you can't walk. And actually when you walk, then patient use the words weakness. Kamzori, मैं चल नहीं सकता, Yes. Guillain-Barré polyneuropathy is a common paralysis in young people, where within 1 or 2 days they develop weakness of the legs and sometimes arms and sometimes only legs, and by the time 2-3 weeks, if they don't progress, after 1 month they start recovering. And if you see them after 2-3 weeks walking, they're walking like that, very high step. That's because of foot drop. They're walking. And slowly over 3 months, 6 they become alright. So you can have this type of weakness like she had, where maybe she could even, if you forced to walk, she would have walked, but like that. Many of them can't move. Absolutely, you are in the bed and your hand and legs you can't move. And that time somebody thought of the diagnosis, what we call as familial periodic paralysis. The name of the disease is familial periodic paralysis. Actually, it's all genetic. This is all genes. In olden days, it was named as hypokalemic. Potassium is a very important from every angle. Heart, muscles, kidney, this, everything. So, people thought potassium goes down in this patient. We call it familial hypokalemic paralysis. Till the genetics genes, when they did this genetic science, they found out there are certain people who get this genetic disorder of the potassium. When the potassium sometimes becomes high in some patients, even high potassium can paralyze you, can affect the heart. So you can get a hyperkalemic paralysis, you can get hypokalemic, and worst is that pure genetic comes in the science when they find normokalemic paralysis. Your potassium is normal, but you get this an episode, we call it an episode of a paralysis, when you can't move your limbs. So naturally, you can imagine, the doctor who has never heard of it, what will he come and diagnose? 100 things he'll diagnose. Shift to the hospital, do an MRI, do this test. But if you are aware of it, fortunately, the hyperkalemic, which is due to increased potassium, or normokalemic, they last only half an hour, 1 hour. Within half an hour, 1 hour, patient is walking. And some of the doctors, specialists who are called, they will not believe it. They'll say she was hysterical. How can a paralyzed patient who all 4 limbs are paralyzed, how can he walk in half an hour? There is no condition where you can do it. They don't know, they have not heard of this condition. That is why they are talking. But if you ever see more potassium, you can always reduce the potassium by giving insulin and glucose. This is the best combination to reduce potassium dramatically. But even if you don't, nothing wrong, because they become normal within half an hour, 1 hour. It's a hypokalemic type where the potassium goes down, where the paralysis can last for 1 day, 2 days, 3 days. आपका वो पहले टाइम जब भी हुआ था कितने दिन चला था? 3 दिन. दूसरे टाइम? 3 दिन. तीसरे टाइम? 3 दिन. 3 दिन हम सब 3 दिन हो गए. That means she has got this 3 days business. It lasts for 3 days. Anyhow, the point is, these are the episodes when you find low potassium. So you can give potassium chloride intravenously. They will recover, no question of that. Now, how to prevent the attacks? Acetazolamide, which is Diamox called in the market, best drug to prevent the attacks. 3 times a day, you can give beta blockers also. I didn't want to give a beta blocker because her normal pressure is 90 by 70. You know, we have Indian women, you'll be surprised, 85 by 60 I've got patient. That much pressure they are moving around, normal, nothing wrong at all. But I cannot give beta blocker to somebody whose pressure is below 90, whose pulse is below 60, for example. You can't give beta blocker. Oh, feels cold, hands in the air condition. These are all contraindication. Asthma, this, that. Who's got a first degree heart block on ECG? Who's got some COPD smoker, oxygen is already 96%. These are contraindication. Anyhow, I didn't give her and put her only in acetazolamide, and if she does get an attack, she can have an intravenous potassium. And but the point is, I got this thyroid test done, and thyroid test absolutely normal, because some of these patients have got hyperthyroidism, and we used to be told that hyperthyroidism can produce myopathy, weakness, muscle paralysis. I remember old textbooks mentioning. Some of them were, I think, this patient. They were just, if you treat hyperthyroidism, they will not get these attacks. Finish. Now that this is coming up and genetically it has been found, now we ask for thyroid in every patient. I asked for thyroid is normal, which means her prognosis is very good, which means Shanta was shouting that I have got serious disease, there is nothing serious. सब लोग हंस रहे हैं, तुमको कुछ serious नहीं और तुम भी हंस रही है. But thank you for coming. आपको बहुत बहुत मेहरबानी. Give her a big hand. This was a patient of periodic paralysis. In the past, it was called as hypokalemic periodic paralysis. In the past, it was also known as familial periodic paralysis. In the books, it is mentioned as in small print. The impression given by the authors is as if it's a very rare disease. According to me, many general practitioners will find
in their practice, patients having this particular illness. It is passed off as hysteria, it is passed off as functional, it's passed off as neurotic women, neurotic symptoms. Only if you are aware of this illness, you will find in your practice off and on such patients who may be males or females or young boys, often after an attack of weakness after eating or after exercise. They find all the limbs become weak, they can't move their limbs. Just because they become alright within half an hour, 45 minutes, when some relations give them coffee, hot coffee or some sugar and thinking there is maybe low sugar attack, this and that, they become alright, the diagnosis is missed. These are the patients whom in the past we didn't know, it was not even described in the books, who had periodic paralysis, not of hypokalemia, low potassium. These are the patients who had normokalemic paralysis with normal potassium or hyperkalemic, high potassium. High potassium can cause paralysis. Even without treatment, they become alright within half an hour or 1 hour. So these are the type of patients very often missed, and they are misdiagnosed. It is the third type, which is periodic paralysis due to low potassium. During this period they develop hypokalemia and you have to pump in intravenous potassium chloride. And these are the patients which are picked up because the paralysis lasts for as many as 1 day, 2 days, 3 days. More than half a dozen times I have seen these patients being admitted to the hospitals and diagnosed as polyneuritis, Guillain-Barré polyneuritis, which is one of the common causes of paralysis of all the 4 limbs in young people, healthy people. And where the treatment is nowadays intravenous gamma globulin, which costs about ₹1,00,000 over 4-5 days. And I have seen some of these patients getting this treatment. And the doctor even attributes recovery to that. Remember that always such patients, the potassium will be low, and if you give potassium intravenously, they recover completely. Even if you don't give potassium, after 2 to 3 days, suppose the diagnosis is missed, these patients can recover and they become normal. They have to be told that there is nothing to worry, this is not a serious illness, it will never remain permanent, and the patients will be quite happy to know that.
Paralysis, the paralysis which these people get is of a lower motor neuron type of paralysis. What is the meaning of lower motor neuron type paralysis? Suppose the hand is paralyzed and suppose I do like this. This is looking for tone. It is so easy to do because there is no tone. Normally there is some tone, but normally all paralysis which you see in the hospitals, which you have been taught, they are all upper motor neuron type of paralysis. Even in hemiplegia, you try to do this, you will find difficult. See, you get so much resistance, and that is the type of paralysis which these people get. Now, this is a purely disease of lower general practitioners, GPs. The physicians may never see it in their lifetime. What an advantage! You should be proud. You should be proud of this. But the point is that the lower motor neuron type of paralysis, which can present acute onset in the young people, same onset, same type, when the specialist comes on the scene, he would like to exclude polyneuritis called as Guillain-Barré syndrome. That paralysis is a serious illness in the sense that paralysis can spread, it can produce, it can affect the chest muscles, you may need a respirator. But in the end, they all recover within 3-4 weeks, 6 weeks. That's not the point. Point is, there is a special treatment of this type of paralysis. In the past, we used to give them steroids in large dose, Steroids in large dose, huh? Not 5 milligram 3 times a day. Abroad, when the patients of disseminated sclerosis, when they get attacks of paralysis, the doctors give them as much as intravenous prednisolone 1000 milligram. You see what is the dose? Important thing is the dose. So if you give them steroids in large dose means normally 5 milligram 3 times a day. In these patients say 60 milligram 3 times a day. Even 100 milligram 3 times a day. That's supposed to be the treatment of the... Then it was found out that it was not very effective. Now they found out that the intravenous gamma globulin, immunogamma globulin, is very effective in these patients, 100%. You give them daily for 3-4 days intravenous, but the cost is 1 lakh rupee. So how do you deal with this? I had a chance to deal with this situation. There was a Pathan, and Pathans are known to have, they've got a lot of money for spending on doctors, 100, 200, 500. But if you ask them 1 lakh rupee, Pathans don't have 1 lakh rupee. So this Pathan developed weakness of the both upper and lower limbs. And they took him to the hospital, straight. The hospital, the specialist saw. According to me, the jerks in this patient are lost. While in the usual familial paralysis, maybe they are not lost. But he said this is polyneuritis. He was sure. And he was not wrong. Of course, there are some tests like lumbar puncture, etc. But you have to be fast. So he said, we'll give intravenous gamma globulin. You give us 1 lakh rupee for 4 days. So the Pathan got upset. The family, they didn't have 1 lakh rupee. And it was already 2 days were over. Second day was getting, this happened on the second day. So in the evening, second day was getting over. They told them, no, we'll take the patient to our doctor, O.P. Kapoor. We'll take him there. Next morning at 6:30 in the morning, this patient was in my clinic. By the time he had 2 days paralysis, upper and lower limb. Now, I'm a specialist. I'm not a GP, but so I said this could be polyneuritis. The jerks were absent, but I said this could be hypokalemic paralysis, which takes about 3 days to recover. He had finished only 2 days. So what trick I did was, I told this Pathan, I said, I'll give you tablet. I gave him a steroid tablet of 60 milligram. Then I gave him a vitamin pill. You take this, you may become all right within 1 day. It may work. Which happened. They went home. They took, next day he was walking about, he was shouting, enjoying. After 2 days, 6 Pathans came to my clinic for a checkup. That he is God. How did he? And those fellows said 1 lakh rupee. He treated the thing. So you can have this problem if you are a specialist. As a GP, all you have to remember is it can last for 3 days. Patient has no money. 1 lakh rupee. You can wait for 3 days. Nothing wrong in that. And exclude thyroid disease. Okay? We go to the next case. The next case we are going to show you of migraine.
Neurological problem. What is the problem? She used to get headaches. तुमको सिर दर्द 3 साल से था ना? कितने साल से?
3 साल से।
3 साल से तुमको सिर दर्द था। लेकिन जब भी तुम मेरे पास आई और वो सिर दर्द उल्टी का ख्याल होता था, जब भी सिर दर्द होता था जोर का। अच्छा, जब भी तुम मेरे पास आई, तुमको ये रोज का सिर दर्द होना शुरू हुआ ना, वो कब से? कितने महीने? 5 महीने, 4-5 महीने?
5 महीने।
5 महीने। When she came to me, that about February, she started getting headaches daily. She's 30 years old. And her mother, तुम्हारी माँ को भी सिर दर्द की तकलीफ है? माँ को
नहीं था ना,
माँ को सिर दर्द
नहीं था।
तुम्हारा ये देखो, मैं इधर लिखा है, तुम उस दिन कौन बोला था तुम्हारी खानदान में किसको सिर दर्द किसको तकलीफ?
किसको नहीं था मेरे साथ सिर दर्द, किसको मेरे खानदान।
तुम्हारी माँ कभी गोली नहीं खाती?
नहीं।
उस दिन जब तुम पहली बार मेरे पास आई थी, तुम्हारे साथ कौन था? तुम्हारा मर्द था
मेरे साथ में?
हाँ
ये था।
हाँ देखो इधर मैं तुम्हारे से पूछ रहा हूँ, इसकी माँ कभी सिर दर्द की गोली खाती थी या नहीं? तुमने देखा है हाँ या ना? खाती रहती। See, I tell you, history taking is an art, because you have to understand these type of people. She is from Rajasthan, and you see this lady. They take doctors as God, they take husband as God. Peculiar personalities they are. And you ask them any question, they don't answer. They say, husband has to answer. Husband has to answer every question. Urine, periods, you ask husband. And these husbands keep a record. How many times he passes urine, how many times stool, periods start how many days, 3.5 days, which day the maximum flow. Husband keep all the record. This fellow is very smart. And I remember now that he came and I saw him, he has given me the full history. He says our mother swallows tablets like hell of headache pills. Just now he said the same thing. Anyhow, the fact is, it's a straightforward migraine, family history is there. What I want to tell you is that she used to get headaches daily when she came to me. For 4 to 5 months, but before that 3 years, she used to get once a while. So what I have done is, I have put her on cyproheptadine. I want to show you, before I show you cyproheptadine, that when she came to me, I saw her weight. And she was hardly 39 kilo. And she has got a good height, you know. तुम साथ में खड़े हो जाओ, कौन लंबा है? वो तुम्हारे से लंबी है? वही हाइट है, तुम्हारी एक ही है, अच्छी हाइट है. She very high. I said, no, she should be much more. She should be 50 kilo. So I said, I must increase her weight. So I said, how to choose a drug in migraine patient? It's an excellent example. Migraine patient, 20% population has got migraine. When do they come and see the doctor? When the headaches become more frequent. Like she came. They are coming daily. Now, what is your problem? Problem is to prevent the occurrence of the migraine. I am not going to discuss how to, during the attack, what to take. Her mother takes, he must be knowing. She can take the same pills which her mother takes. That is not the point. Point is, I want to prevent these attacks. And now I have to select the drug. See, I have to select the drug. What should I give her to prevent migraine? I saw her underweight. I was very highly impressed. I said, I can give cyproheptadine 3 times a day. 3 months she'll put on 10 kilo weight and headaches will go. 100%. So you can see what a publicity I'll get. That she will have put on so beautiful weight and no headaches. Migraine headaches have gone, disappeared. Before that, she had come from the village. I said, she has no symptoms. I said, let me take an X-ray and make sure that she got COX also, pulmonary COX. And I asked for a chest X-ray. She had no symptoms, nothing. And see this patch here. This man is affording and all. I asked for a CT scan. It is COX. And mind you, they were not very, I was only thinking whether I should give her some drugs or not. But put her on anti-COX also. The fact is, कि उसका कितना वजन बढ़ा? 9 kilo. 9 kilos weight she has put on, in 3 months. 9 kilo और सिर दर्द गुम. क्या? सिर दर्द गुम. This is called selection of a drug for a particular patient. This is not Golwala's textbook. What are the drugs which can prevent the headache? Number 1 is cyproheptadine, number 2 beta blockers, number 3. On a private patient, how will you select the drug? If my patient is underweight, I will give her just cyproheptadine. Suppose this patient was a fat patient and little alcoholic and same problem, blood pressure 140/90, not very high. Then I will give beta propranolol 40 milligram 3 times a day for 3 months. 90% chances it will work. I am telling you. That's a drug for that patient. Suppose, see, I am looking at her. She looks very happy. You look at her face, दिखाओ जरा face. That she looks like happy. वो सास बहू सीरियल यू सी नो, ये तो खुश दिखती है एकदम. अरे इसका मतलब तुम्हारा मर्द भी तुमको इतना अच्छा लगता है, सास भी इतना अच्छा लगती है तुमको, इतना she has no depression. Suppose you find joint family girl comes for frequent headache and you find she is depressed. You give her amitriptyline 25 milligram at 8 p.m. Headaches will, frequency will go, migraine will go, and then it will come only once in a way. Suppose there is nothing to help you, then you use the anti-epileptic drugs, sodium valproate. Today the latest as topiramate has come. Topiramate, beautiful drug. These are neurological drugs used in seizures, epilepsies, and which we are using in migraine patients. The attacks come down. But the fact is, that this lady has put on 9 kilo weight, headache is gone. बहुत बहुत धन्यवाद. Give her a big hand. बहुत बहुत आपको तो इसलिए हमको ये सब आपको तकलीफ किया. नमस्कार. अच्छा.
In this case, I wanted to bring out a few points in a patient of headache. Number one, migraine is the commonest cause of headache, and there is no investigation to confirm migraine. Migraine is diagnosed only by history taking, a proper history taking, and I showed you the difficulties of history taking, that you have to take the help of husband in illiterate patient to find out if the other family members are also getting headache. That's the first thing. The second thing, that migraine is basically of two types. Has your patient got episodic migraine or a chronic migraine? Exactly like asthma. A bronchial asthma is as common in normal population as is migraine. Both the illnesses behave same way. Either some patients have an episodic migraine like episodic bronchial asthma, or they come to you for chronic asthma, chronic migraine. Episodic patients usually don't land up with the doctors, so often they don't want to take treatment. But an episodic migraine attack is treated by painkillers, which could be any painkiller. It's not necessary to give sumatriptan, etc., etc. So we come to the next, chronic migraine. Chronic migraine is a migraine where the patients start getting the attacks very, very frequently, which interfere with their lifestyle. That's how they'll end up with you. Today, we've got lot of drugs to treat chronic migraine. And I was trying to tell you in this, while showing this patient, that I selected for her cyproheptadine because she was underweight. And you can see that he should not only put on 9 kilo weight within 3 months, the migraine headaches, they don't disappear permanently, remember that. This will now become a case of episodic migraine. Next time whenever she goes in the sun, shopping, etc., she'll again get a migraine attack and she should keep a painkiller in the pocket. And finally, I wanted to show you that any underweight patient, before you put that patient on a diet to put on weight, please get an X-ray chest done. In our country, and especially in this type of population, the tuberculosis is rampant and is silent. No fever, no cough, nothing, no hemoptysis. And you will be benefited out of 100 patients, at least 10% patients you will find a positive focus in the chest. Now you have to decide whether it's an old tuberculosis or a fresh tuberculosis. Now ESR can help you in that. CT scan can help you in that. In this case, of course, because they were rich, I got a CT scan done which showed an active infiltrate.
Most migraine, as far as I am concerned, naturally I will have patients of migraine who are chronic migraine. and the doctor, the GP wants to know from me what drugs to give to prevent. And I must tell you frankly, see, migraine is a very funny disease. There is no proof that she has got migraine. And she is poor, he is having, then how much is due to tension headache? Tension headache is a very big problem. And I am surprised that some of the new books now are more or less removing tension headache. They are putting tension headache in the small print. No, tension headache is a major problem. In fact, most of the patients of migraine, they also get tension headaches, or most of the tension headache patients also get migraine. Both of them, which one is due to migraine, which one you have to sort out. Very difficult. Treatment is very difficult. And I want to tell you one thing, that this is one disease that I will not like to, really speaking, have in my practice. So when I get fed up, nothing is working, then I have got three things which I do. Number one, I give them a large dose of steroids. Just like in asthma, you give a large dose to start to get rid of the asthma. Here it is not even that much dose. There is not, here larger dose. You can give 60 milligram per day for 2 weeks. Sometimes it works, often it does not work. Second thing, I send them for botulism injection. You give them botulism injection here at the back, because most of the headaches are at the back also, occiput. Tension headaches are also there, migraine headaches also there. So we can give them that works. In some 30-40% patients, it works. You spend 20,000-30,000 rupees. It works for 6 months so easily, no problem. Sometimes this doesn't work. Then I hand over for non-allopathic treatment. Whether they want to have Chinese, whether they want to have Ayurvedic or homeopathic. But on the whole, I am not happy to treat such patients. Next please.
ભરતભાઈ આવી ગયા. કેમ છો? મજામાં? જરા બતાવો જરા. ભરતભાઈ જોયું ત્યારે તમારા વિડીયો ઉપર કેમ લાગો છો? હીરો જો તમને જોઈએ. He's a little staring. First time also I was wondering whether he had any thyroid problem, T3, T4 normal. But anyhow, his problem was he had this weakness, and he's a businessman, and the main problem was his voice. Where is it? His weakness, he couldn't walk well, and इसको जरा ऊपर कर दो. ऐसा. शुरुआतમાં તમને નબળાઈ પણ હતી? હા. ચાલવાની તકલીફ હતી? હમણાં ચાલીને બતાવો જરા. જો શ્યોર, સોરી, ચાલ. વેરી ગુડ, વેરી ગુડ, વેરી ગુડ. શરૂઆતમાં તારા એટલી સરસ નહીં હતા કે ચાલો ને તમે? હા, તમારી મેઇન પ્રોબ્લેમ બોલવાની. સો but the problem is main, just hear him talking, just hear his speech. His main problem was speaking, that he could not. તમારી શું તમે કહો છો? તમારે બોલવાનું?
એટલે મને બોલવામાં થોડી તકલીફ થાય છે.
હા.
જ્યારે એન્ઝાયટી વધી જાય ત્યારે વધારે થાય.
હા.
એટલે આ સ્ટીફ થઈ જાય મસલ લેફ્ટ સાઈડમાં.
હા, પણ હમણાં તો તમારી અવાજ તો એટલી અમિતાભ બચ્ચન જેવું એટલી લાઉડ થઈ ગઈ.
હા, હમણાં તો બરોબર છે અત્યારે.
You can hear him. You couldn't hear him. He had such a low voice. You see, in Parkinson, the volume of the speech goes down. His volume was so poor, he could not throw out the words. And the other thing is mumbling.
Yeah.
She was so mumbling, which mumbling has become now better, and the voice, now the throw of the voice has become beautiful.
Previously, I used to speak like that. Now I can speak something clearly.
Clearly. See that? How clear? I mean, imagine with these drugs. I tell today, we've got beautiful drugs for Parkinson, I'm telling you. He is taking those tablets. You see, the Parkinson disease is due to, we'll discuss it when we discuss neurology, that L-dopamine is deficient in the body. Okay, I can give L-dopamine from outside. Now, that will get destroyed, so we give him with carbodopa. So that doesn't get destroyed. So he is also taking a tablet which has also got entacapone, which is COBT inhibitor, which maintains the life of the drug for a longer time in the day. And along with that, he is also taking ropinirole. Ropinirole is excellent non-ergot drug which has come for amantadine also. 3 types of drugs he is taking. Now the point is, I also send him for a physiotherapy of his voice to
Speech therapy.
Dr.
Natasha D'Souza.
Natasha.
D'Souza.
Now, Natasha D'Souza, who audiologist and speech therapist, she has trained him to speak. કેમ લાગ્યું તમને?
Yeah, something better than to.
But હમણાં તમારી આવાજ તો બહુ loud છે.
Huh?
His voice is so nicely, I can hear. You couldn't hear his voice. It was so bad, I tell you. And the other thing is that mumbling, what he says, no? તમે શું અવાજને શું કહો છો? આગળ તમને શું હતા?
એટલે પેલા મોઢું ખુલતું નહોતું, બંધ મોઢું રાખીને બોલવાનું ટ્રાય કરતો હતો.
And fast. It reminds me that in that one of the films, Mukesh used to sing sober songs and all that. So I think one of these films they show that hero is singing, and that Vijayanti Mala is trying to seduce him. And that I remember that song Mukesh is singing that lap re, lap re.
શારદા film.
Sharda film. Are, તમે તો સારા હીરો છો. Sharda film, વિનોદ. And then in between I say lap re.
મીના કુમારી was the heroine.
તો તમે આજે હું કહું છું ઠીક કહું છું? બોલવાનું જેમ કહે છે ને લપ રે, લપ રે. In the same song is
correct.
He was like that. તમે આમ હતા.
Yes.
He was so mumbling, I couldn't understand what he is talking. And voice,
but
volume.
Natasha helped me a lot.
Natasha. So Natasha, I'll bring her on the stage and show you. She's a speech therapist, an audiologist. Now she has helped him, and I think I'm highly impressed. His volume of the speech is better than me.
શું વાત કરું?
મારાથી હું તમને કહું છું, હું તમને હમણાં ફિલ્મ લઈશું, બનાવું છું, ટીવી સિરિયલ બનાવું છું, તમને ગાવી છે? હા, તમે ગાઓ, સેમ ગાઓ એક લાઈન.
અરે
જી વળી. હા બોલો.
चलती चली जाए जिंदगी की डगर, कभी खत्म न हो ये सफर, मंजिल की उसे कुछ भी न खबर, फिर भी चला जाए दूर का राही.
Every word is clear. He is not slurring at all. Very salah, તમે hero hero. Beautiful. Now, second thing I'll tell you about his problem was his handwriting. You see, these people, Parkinson, every time they come, I make them sign. Get your signature?
No. Previous signature.
No, but this is previous. And Hamana, what is the position at the moment?
I'll have to
Is
sign.
the bank accepting?
No, sometimes they reject.
Sometimes they reject, but sometimes they accept.
Sometimes they accept.
Dakwa, this is original, and let me see now. What is it?
No, I
Yes.
can't do it.
Nahi, plain paper.
But I can't do it.
Not bad, Not bad, જો ક્યાં છો તમે? ક્યાં છો? આગળથી જો મને લાગે છે બહુ આગળથી ઇમ્પ્રુવમેન્ટ. You see this? Always go on taking their signatures. Because handwriting improvement is an excellent method to judge how much is he improving. And I can see when he came, it is in the file, everything in the file. Very bad. Of course, I got his dopamine scan done, spec scan done. ये जरा देखो. Just because I am interested in some academic thing. તે બરોબર છે. Okay. He has got severe dopaminergic deficit noted in bilateral striatum. Corpus striatum, you can see the dopamine cells with a SPECT scan. And you can see that today, I mean, imagine what advances have taken place. I'm just trying to tell you that today we have advanced so much that we can diagnose these illnesses, we can treat these illnesses, and if this gentleman doesn't respond to the drugs, maybe my dose may not be very up to date. I can even send him to a neurologist who does only Parkinson. He might adjust a dose better than me. Suppose he doesn't respond. But suppose he doesn't respond. We can also put electrodes in his brain. We can put electrodes on both the sides, stimulate the electrode in thalamic area or subthalamic area, depending on that. And this man can do a normal work. તમે ફેક્ટરી में જાઓ છો રોજ?
Yes, I also drive very well.
You are driving the car also?
Yeah, I came from Mulund now. Right
From
now.
Mulund you drive. Very good. Give me a big hand for coming from Mulund.
This case has been shown to impress on the family physician. Don't miss Parkinson's disease in private practice. Remember that these patients come only for weakness. They cannot walk properly and they feel they cannot talk, and it can be mixed with any number of diseases causing weakness. And unfortunately, till now we had no test to confirm the diagnosis of Parkinson. It's a clinical diagnosis. Though I showed you that we have got nowadays nuclear scans where you can show the dopamine cell deficiency. Though it's not necessary in every patient to do it. But what I wanted to show you in this case, a few aspects of Parkinson's disease. That when the patient comes for a presentation or some complaints, then for example his main complaint was when he improved in walking after the anti-Parkinson drugs, his voice remained bad. It was very low, he was mumbling, you couldn't understand anything, and he has got a business factory, people couldn't understand him, he couldn't conduct his business. So I looked after that angle. I increased the dose of the drugs, I gave him a combination of anti-Parkinson drugs and sent him for speech therapy. Remember that speech therapy is one of the best therapy for such patients, especially to bring out the volume. And today you could see that his volume of the speech came back so beautifully and the mumbling completely disappeared. His wording was so clear that when he sang, you could hear every word distinctly. The next thing what I stressed was, remember that their handwriting, and a businessman like him who is to draw the money from the bank every now and then, the handwriting must improve. You have to adjust the dose of the drugs with a different combination in such a way that his, for example, handwriting also must improve. Otherwise, what is the sense? He cannot do business, he cannot earn money. And here you could see that after the treatment his handwriting is also improved. And I was trying to tell you that today Parkinson is treatable in majority of the patients with a proper combination of drugs. And if you cannot treat Parkinson's disease, or if they have got tremors, some of them have too much tremors, then you can always do a interventional treatment where nowadays we put pacemakers. It's like pacemaker in the heart. We put electrodes in the brain and with a remote control here in the chest, and the patients do very well.
This was the story of Parkinson. If any patient came with these tremors, what are these tremors? Resting tremors. Most of the tremors are not resting tremors. They come only on stretching the hand, on doing some job. These are resting tremors. Resting. They only disappear in in sleep. But these tremors are absent in 20% of patients of Parkinson. 20%. So if that is so, you must diagnose Parkinson's disease by other methods. Main thing you remember, in Parkinson, the first symptom is what is called as hypokinesia. What is hypokinesia? Press my hand, press my hand, press my hand, press my hand. He is pressing hard. So this is normokinesia. This is normal thing, power and all that. But if this power, so while walking, for example, you are walking with both the hand and becomes less, then you walk slowly, the hands move slowly, everything becomes slow. Hypokinesia. Today these words are being used by cardiologists in the heart. That muscle is hypokinetic. That's the first most important thing. And remember, Parkinson could start on one side. Diagnosis will be missed. And I would love to have a case of Parkinson's disease, because you get so much publicity. One patient will bring you 10 patients, opposite of migraine. So, this is the first thing. The second thing is the rigidity. Rigidity. So, when you examine the nervous system, how do you examine the rigidity? Now, I'll give you a very easy method of examining the rigidity. You see the wrist and do like that. You don't move. You don't, let me move. See, I'm moving. So, he has no rigidity. If there was a rigidity, I won't be able to do more than this. I'm doing this. So, this is simplest test in a patient who complains of weakness. Has he got Parkinson, rigidity, and the rest of the rigidity? Again, all this can be severe, mild. But one thing I tell you, I am very proud of our allopathic medicine. The way in which I have seen the treatment of Parkinson's disease growing, the way in which I have seen, and I have treated. God has made me very lucky to treat this patient in that. You see, dopamine. First, they found out 40 years back, dopamine is deficient. So they started giving dopamine injections. Those days I had a lot of Arab clients, very rich clients, and it was not easily available dopamine, very, very costly. I remember one patient from Doha, Qatar, Parkinson's disease. I visited him and he managed to get dopamine injection. I gave dopamine, and the amount of problems we had, I cannot describe. So much so, matron was saying, you take away your patient, don't come to our hospital, because his blood pressure was shooting up like hell. He was getting cardiac arrhythmias, plus mental. He was getting so much anger, plus he would catch hold of the nurses and beat them up. I mean, amount of side effects which I saw in that patient, I tell you. And now I know they were due to dopamine. So now, because we give levodopa, it gets converted to dopamine, goes fast to the brain. Now we give them with carbodopa. So carbodopa sees that it is not quickly broken into dopamine. So half the thing goes, half remains. And now we have got another drug, entacapone. Entacapone, on the top of that you add, that smoothens the whole thing. Smoothens the whole thing. The whole drug is now going slowly to the brain. And all the hypokinesia, walking, this gentleman was not walking like this, like you saw today. He was very, which they call weakness. They use the word weakness. Similarly, rigidity responds beautifully. Similarly, his voice responds. Tremors don't respond very well. Tremors don't respond very well. Anyhow, but all these drugs have come. And now this Rosigilane which has come, which I am giving him, non-ergot. Formerly they were ergot preparations. The ergot preparation we used to give for this, beautiful, very, but the side effects were so many. Ergot preparations caused mitral stenosis, tricuspid regurgitation, heart. They went to the heart and caused heart disease, valvular. Unbelievable, unbelievable. Anyhow, we stopped ergot preparation. Propranolol is non-ergot preparation. Salicylic, another thing which is added to, again, non-ergot preparation. These you have to titrate. The whole treatment of Parkinson lies in time. And money. Patient must have a lot of money. You have to spend a lot of money on the drug. And you have to spend a lot of your time and find out the proper combination of the drugs. Otherwise, you give them more drugs, then they have got all dyskinesias, we call them. And many of them don't mind. In England, I saw a patient, and Mr. Johnny, who was having, I said, but what about this? I don't mind. I can go and dance. He's saying, if he can go and dance, what is wrong with this movements? So they don't mind, but it is wrong. We should titrate it in such a way that it is not hyper, it's not hypo, and similarly, the surgical treatment has increased, has improved. I have sent dozens of patients of hemiplegia, Parkinson, one-sided, for surgical treatment, striopelidectomy. Then all this corpus striatum, they go and destroy there. Moment they destroy there, that immediate, like magic, finish. The tremors disappear. And the patients come out of the operation theatre, walking, and everybody is looking at him, and everybody admiring. And my name also, he suggested, देखो क्या किया कपूर ने, देखो क्या कैसा, till I started getting bad luck, till I started getting patients who were having this, who went in the operation theatre, who were given this, they disappeared, but they came back hemiplegic. They died of hemiplegia. Hemiplegia, all fibers are in the corpus striatum. Remember that. A dangerous area, very close. Bad side effect, they stopped doing it. And now they started doing only electrical stimulation. Thank you.